Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 69, and for most of you who are either concluding the ACC or have just returned like me, I hope that you've had an excellent Congress. Sameen, you've had a major accomplishment. This is if the camera could show this here, I wanted to.
Let him be.
All right,
Yes.
here is the new textbook, a practical manual of interventional cardiology, which you are releasing soon.
Yes, actually, this is the work of many years. What we used to have just simple cath lab manual, intervention manual, and what we are trying to do here with Anu is the main leader on this. That take all step-by-step approach to all situation scenarios in interventional cardiology, starting with the anatomy, with the selection of the antiplatelet therapy or different interventional devices and type of lesions and so on and so forth, and structural heart cases, and so all have been put together as a technical manual. So it basically is not a theoretical, it's not much in terms of references. We are limited to anywhere 1 to 5, but all what is done at Mount Sinai has been put into this book, and I really ask Anu to comment on it, because she did tireless work for more than a year along with our interventional fellows to make this happen.
Yeah, this I would say with the interventional fellows, a manual, like we used to have the pocket book, Oxford handbook, which we used to use in England, and here is Washington manual, where before entering a case, if you want to quickly have a reference, how can I do this complex bifurcation, rota, even left main stenting. So we start with the basic of even as simple as what would be the good angiographic view if you want to see particular lesions, that's given there. But more important, I would say, stepwise, even for bifurcation, if you see the book inside, it will tell you every step of how would you do all the bifurcation technique. If you go to valvuloplasty, the exact way of how you want to do transeptal. Essentially what we are teaching the fellows in Mount Sinai Cath Lab to become proficient in doing moderate to complex cases in a simple way and do it right. This is what we practice here, and the goal was that whatever we practice, that if we can try to teach people outside how to do it the way we want to, way we would do it here, and that's what that handbook is all about.
Look, it also has some very beautiful illustrations, and I know many viewers have been asking us where could they get this supplemental education. So here you have it, and hopefully you'll find it useful.
And all that pictures were hand drawn by myself and all the fellows who are in there. All the pictures were hand drawn, and Springer, the publisher, actually did a tremendous job in making it come to life.
We never knew there was an artist hidden there behind you.
Well, of course, and actually I really had to thank one of the fellow, Anita, who is edited all the chapters, particularly all the fellows. So she was also help a lot to put everything together, and like anything, any good movie, you already have a sequel, so that they're already thinking about making a practical manual interventional cardiology part 2 or edition 2. So they're already working on it. So with that note, we start our today's case. These are our supporters. The disclosures, nothing has changed. The case is a 47-year-old male who is the diabetic patient, has a new onset angina last month after having a strongly positive stress perfusion imaging involving both RC and circumflex distribution. At that time EF was borderline. Patient had a cath, had II Vessel disease. Will show you multiple lesions of the RCA and one lesion in the circumflex, and patient underwent stenting, and angiography will go to the angiogram now.
So this is the left side, left main is non-obstructive. You had the LPL disease 80-90%, which has been stented already, and the LAD was non-obstructive, and this is the case that we are. EF, actually if you see, just the apex may be just mildly hypo, but you have a 80-90% proximal disease, maybe moderate disease just at the just at the level of the RV branch, and the most important disease is a distal RCA, and the PDA it is a bifurcation which we would say 1 0 1. That means the distal branch, which is AV continuation, does not have disease, but you have the ostial PDA 80 to 90, distal RCA has a disease, and the ostium of the PDA, the origin, if you can just see here, the origin of the PDA at the within the disease has a nice angle, and that is what we are going to discuss technically, how would we wire this kind of a side branch and other devices that we are going to be using.
Yeah, therefore, it is the angulated branch, and remember, as Anu mentioned, that it will be proximal lesion, so 1. Now question always comes in the bifurcation, what is your main vessel and what is the branch? By definition with the Medina is, your larger the vessel is your main branch, no matter what supplies the myocardium less or more, maybe AV continuation which does not supply the myocardium, but that is your main. So therefore, here by size wise AV continuation is bigger than PDA. So it will be a 101 lesion, and the second lesion of the PDA is the one which is very angulated. So that will be the technical challenge. If we can go back to our slides, patient is on optimal medical therapy. These are the angiography we have showed, multiple lesions in the right coronary which will come into account, proximal and mid, moderate being, and of course syntax score was 12, and patient is here for PCI. Now one question is that in this angulated lesion we have few devices at present available. One is the venture, then supercross at 90 degrees and 120 degree angle, and but during the case will show venture which you can change after getting into the vessel compared to supercross which comes with the set angles of 45, 90, 120 and extra tip of the 120, and clearly these have helped in crossing many of these angulated lesions with a great success, and clearly this patient is appropriate because of high risk scan as well as multi-vessel on optimal medical therapy. Okay, so that will be our plan in this particular case, and while we are getting ready, maybe I will ask Anu that which angulated catheter will be your choice in this particular case, Anu?
If you can go back to that picture of all those catheters, yeah. So let us go over this newer what we call these catheters. Now the venture, you have two, you have over the wire as well as you also have what's called as monorail. So great thing about venture is one, that you can use it monorail, so you can use any kind of specialty wire. Usually in this kind of situation you would like to use fielder, whisper. You make the curve and you go all the way to the distal part of the vessel, and once you are there, then you make the angle of the venture. As you keep pulling back, you will know you have to rotate it 3-dimensionally to understand where the side branch is, and then you use your wire to get into the side branch. So if you have over the wire venture, the great thing would be that you have crossed it, then you take the venture out and then you proceed with your PCI. Many times what can happen is you might go with the wire, but by the time you reach there, the side branch, the tip of the wire could have had some problem. You may want to change to a different wire. That is not possible if you actually use a monorail. So in that case, this is what you need to decide before you pick the device, that you may need over the wire venture in that situation. Supercross is all over the wire, and based on the angle of the side branch you have to decide whether you are going to go to 90 or 120, if you can show that slide, and then how would you decide. So if you see this angiogram, if you can show the angiogram, in this particular case that I would go, if I am going to go with the supercross, then I would go with the 120 supercross, go all the way to AV continuation, start bringing the supercross slightly, start pulling it back, and when you think you are at the PDA, just use the fielder wire to get into the PDA. The other thing also is the size of the vessel is very important before you decide which particular catheter you are going to use. So if you see here, RCA distal is almost 3.5, AV continuation is 3.0. So in this case you can go either venture or supercross. If you have a 2.5 vessel or the lesion of the main vessel is really tight, there may be issue using the venture. for the venture to make the turn and the curve, and you have to give some dye, you may not be able to do that if the vessel itself is 2.5 or smaller. So that also you have to take into consideration in deciding which particular catheter you are going to be using. So I think in this case we will go with the Supercross 120.
Yeah, and you know, clearly as mentioned, the basic difference in Supercross microcatheter versus venture would be that one is the fixed tip, whatever you decide, while compared to venture you can change bend the tip in the vessel to your liking, although in the very tight lesion it is a difficult.
Yeah, in tight lesion it will be very difficult. Show the venture when you are making the tip.
Yep.
So this is how you do it. You see those two fingers that you rotate it clockwise, and as you do that, the tip which was straight start making the curve. So for that you need the vessel, you cannot do it if the main vessel lesion is tight and the main vessel is small, which we are talking about 2.5 or so.
I'm glad you showed the display. They both come, all three are actually manufactured by Vascular Solutions.
Yes, yeah, they are now.
Yeah.
They have been taken
also?
up. Yep, all of them.
Oh.
Used to be St. Jude's, they gave up and taken by Vascular Solutions. So there is no competition. You just have to decide what is best suited for you. And now quickly we can go with the 2 points. In this particular case, we'll talk about the bifurcation lesion. We have talked almost every third. Our webcast is about bifurcation. So we'll touch on some of the evolving techniques. And then two important trials of ACC this week, which kind of game changer or practice changer, Matrix and Pegasus. Now clearly the bifurcation, we know the simple classification which has been incorporated now in the syntax modified from the Medina, Duke and ICPS classification. It basically tells you where the lesion is, but also just want to say that many times we may start with a particular type of bifurcation, let's say type A, where the lesion is proximal. You do a balloon dilatation, you block the distal vessel or the side branch. So A then rapidly become D during the case. So we always have to be very preview of those that lesion do change during the intervention. Key is in the bifurcation lesion, side branch is the key. Because of the angle of the side branch and the side branch size and the ostial stenosis of the side branch, everyone has shown to be a predictor of your overall outcome after the bifurcation intervention. Now, we also always comes that do we need to stent the side branch, and if you do, you want to put a various two-stent approach, whether it's a kissing, the crush, or the double kissing crush, or T-stent, or culotte, or simply we just leave it across, one stent technique, and sometimes we may open the ostium of the side branch. So these are the various technique in which you decide in particular case. In this particular case, the side branch of the AV continuation is no disease. So our goal will be to put a stent across from the distal RCA going into the PDA, and we actually have a plan to show OCT also. Hopefully, if the time permits, to see that what is the involvement of the distal AV continuation once we put a stent across the AV continuation. And so therefore, what are the main technical issues nowadays? One, should we pre-dilate the side branch? Should we jail the side branch wire? What is the impact of side branch angle? Then should we stent the side branch, and should we do the final kissing balloon inflation routinely? So those are the 5 points I quickly talk. One is, should we pre-dilate the side branch? Clearly that if you have a very significant lesion in the side branch, it's better to do a pre-dilatation, particularly if it's a 90+%, because then you guaranteed going to occlude that side branch. So therefore basically it makes sense that that you dilate in a very tight lesion. And selection of the device usually is the atherotomy technique. You can use high pressure, but that can cause dissection. The whole concept that should you do a drug-eluting balloon still need to be panned out. So data are being done at present, studies are ongoing to see, but just doing a drug-eluting balloon dilatation of the side branch preserves it, although some trials have been borderline results, is not consistent. Then the cons of doing a side branch pre-dilatation is that you may dissect, and then now you have created a false lumen, or you now have to put a stent in the side branch before you even start. And also we learned that even after stenting, don't go after every side branch which looks hazy 60, 70, 80%, because data have shown that even your lesion which looks 75-80%, you do FFR, that only 35-40% will have a significantly lower FFR, whether your cutoff is 0.75 or 0.8. Majority of them, it's just a visual artifact, and therefore don't go after unless patient is symptomatic or decreased flow or electrocardiographic changes. Then second question, should we jail the side branch wire? Where the purpose, there is one study showed that by leaving the side branch wire, you improve the TIMI3 flow from to 90% from 75 if you don't jail the side branch. Many hypotheses for it. One of them is just you have a foreign body in the side branch, prevents the snowplow effect, completely occluding the side branch. Second is that just it changes the side branch angle, because and of course it outlines the position of the side branch for rewiring and so on and so forth. Problem, cons, chance of wire fracture, loss and stripping could happen, particularly if your wire is curled or it is in the third or fourth small branch. And many times what happens is when you try to take the wire out, your guide sucks in and guide cause dissection. So that we teach, once you are removing the jailed wire, make sure your guide is disengaged far away so it does not come inside. Then comes the bifurcation angle. A lot has been written about now in the last few years about the bifurcation, particularly the pre-bifurcation, which is the, let's say from the left main to the circumflex, or distal bifurcation, which is between LAD and circumflex, or maybe LAD diagonal. And this actually have shown that there is some correlation of various angles. Now one of them has been shown is the systolic and diastolic range, defined as absolute difference between diastolic and systolic bifurcation angle less than 10 and more than 10. In this study showing that whether your angle, bifurcation angle was 82 and above, there was no difference. What really made is the SDR, which we call systolic and diastolic range. That basically means that if your angle is more than 10, it is better region, because vessel is saying that it's not rigid, and less than 10 is associated with a bad outcome. Now Anu has now done a lot of 3D OCTs, and maybe can tell us that what they are noticing or encountering in these doing a OCT of this bifurcation lesion. Anu?
Yeah. So if you can see here, this is an LAD diagonal, and that study that Dr. Sharma just mentioned, most of they were in the left main. It's left main, LAD and circ angle. But more commonly, what do we see in bifurcation is LAD diagonals, that OMs, which is essentially circumflex OM LPL, or the case that we are just showing, which is the distal RCA PDA. And we all know maybe the best thing would be to stent and come across, stent across and come out. It's very clear that if there is no side branch disease, that is the best technique to do it. But still, I would say between about 5 to 10% of the time, even if you do nothing to the side branch, you stent across and you come out, what often we see is that hazy look that we just mentioned. Patient may not have acute EKG changes, but we will have residual chest pain. And always the question to the interventionalist, do we go back, do we dilate the side branch, or can we just leave it alone and come out? And that is where we are thinking in this particular case that I am just showing you here is this LAD and D2. If you see here, the disease is, if you don't see what the arrow right here, this is the disease in the main vessel, no disease in the side branch. And what you have is, this is actually reconstruction you do later on with the 3D angiography, where it's talking about the angle. The angle they're talking about is angle of the side branch before, and this is the other angle, the post angle, which is the angle after the side branch. And what we have been seeing in this, okay.
Right, keep going back.
Back.
Okay, 1 second. Sorry. Yeah.
Okay, so if you see that, you are in the first picture, pre-PCI diameter stenosis, when we know that QC always shows lesser diameter stenosis was significant disease, but after stenting, if you see, the angle actually changes, which we more often see when you stent across. But more important is what happens to the side branch. Just by the 3D QC angiography looks like it's fine, you don't have to do anything. But if you look at the angiogram, which is post PCI, again is the same thing, maybe a 30–50% disease right here.
Yep.
And then you have the so called hazy look, but this is the OCT that we do pre, where there is LAD and D2 which is nicely shown there, and this is the reconstruction that you can do with the 3D OCT using the MEDIS system. This is how your ostium looks before, this is how the ostium looks after. You can see the stent strut that is crossing across, and this is what you actually see is that hazy look that you see after you have stented across a side branch which does not have any disease. And why you get that hazy look is right here, is that little plaque shift that has happened, which is covering some of the stent struts that we are seeing.
And this will become more important with the bifurcation with the BVS.
This is will be more important when we are doing the BVS, which more often we have seen by using the BVS that there could be some side branch, more side branch pinch or snowplow effect, or even if you want to do bifurcation stenting with the BVS, if we can understand this better.
So lot has been written in terms of this bifurcation, and then question come down to one stent versus two stent. Very simple. One stent is okay and simple, but may have difficulty in rewiring or inserting second stent as a bailout. Or if you apply two stent, guaranteed coverage of both lesions and the end, but some data have shown higher MACE, TVR or stent thrombosis in many studies, and although the DK crush techniques have shown the two stent approach to be better than single stent. And then of course two stent, what technique which you use, I would say very simple message. If it is a short lesion of the side branch and side branch angle is more than 70%, it's a small vessel, patient is issue with the depth compliance, you put only one stent. Two stent you put if there is a diffuse disease of the side branch and it's a large vessel. And of course we have to make sure patient is going to take a depth for the long time. And of course the technique is what you prefer. Then question comes, the fourth question is, should we do final kissing balloon routinely? Clearly that you want to put a stent across, if there is a TIMI3 flow, leave it alone. You need not to do anything, because no matter what you do, once you are going to wire the main stent, you are going to deform it. Even if you try to then put a stent in the PTC in the main vessel, you will always have deformity of the stent. And now then also there is a lot data now have come that should you do a kissing balloon inflation or you do a sequential balloon inflation of the side branch and the main vessel. The advantage of the kissing balloon is that facilitate correct distal stent sizing, scaffolding of the side branch ostium, because one stent become 1.1, cover the ostium, and then access to the side branch is preserved in the future, let's say for the distal left main, and maybe lower thrombosis. But of course it complicates the procedure, that's a disadvantage, and it may create the issues with the stent struts. So one thing for sure, studies have shown that if you put a two stent, this is the data from the Cactus crush, that if you leave two stent, you have a higher, and you did not do a kissing balloon inflation, you have much more worse outcome, 75% event-free survival versus 90.5. So that with the two stent, final kissing balloon is a must. Now what about if you don't put a two stent? Then we have a randomized trial which is called the Nordic Bifurcation 3, kiss or not kiss, showed that routine kissing is not necessary in the large 450 plus cases. So key is the routine kissing does not add any advantage, angina, stent thrombosis or so. Of course if you have TIMI3 flow, you need to go to the side branch. Then lot of data have emerged that rather than you do a kissing balloon dilatation, which would really cause deformity or over the protrusion, or I would say over dilatation of the proximal segment, that by using the stage intervention, the stage dilatation, that you do a dilatation of the diagonal side branch, then you dilate the main vessel with the appropriate one-to-one sizing, is better, keeps the geometry better, and may be associated with less turbulence. And this actually have been shown in many of the studies, and associated with lower malopposition of the stent. Then of course the bifurcation stent will change this landscape, although we are still working on it. As you know, the Triton trial overall was negative, but still the bifurcation stent undergoing the major trials. Then second issue quickly is the two key trials with the Matrix and Pegasus. The Matrix trial basically was that how can you minimize the adverse hemorrhagic event by transradial access site and systemic implantation of angiomax. So, that is basically the matrix stands for, and it was basically compared the transradial to transfemoral in about 10,000 patients, and then subsequently there were 1-to-1 randomization to bivalodin versus heparin plus minus 2B3A, which was used in 25%. In this study, actually in the bivalodin they have an infusion stopped after the procedure, or you continue for 6 hours post infusion. These are all acute MI patients, and the primary endpoint are usual death, MI and stroke, and NACE endpoint with the bleeding, and so on and so forth. And basically we found that the transradial again is associated with a lower MACE rate at 30 days compared to the femoral. And you can see here the second NACE, which you include the bleeding, as you can see the difference even become much more significant. The number needed to treat becomes 53 to decrease 1 NACE event. And this is basically, I have put it here, the femoral versus radial, that clearly the radial is associated with a lower MACE, lower NACE, lower trend towards lower MI, and you can see here the death is significantly lower, and of course lower bleeding. Now, if in this study, if you compare with the bivalodin versus heparin, as you can see there is no difference in the MACE and NACE, but there was a lower mortality. And so the first time again we have the data of the bivalodin showing the no difference in the MACE, but more importantly lower mortality in the trial, and the bleeding also was slightly lower in the bivalodin group. So the matrix trial basically is the game changer, what I would say, because again has confirmed that in patients with acute coronary syndrome, MI patients, that radial approach is better. This is being published in Lancet. Then second is the Pegasus TIMI 54. That is the what happens to the patient post MI. If you continue, we know that post MI, post PCI, you need to give it for 1 year. The antiplatelet therapy, that was the part of the Plato trial, and so ticagrelor along with the low dose aspirin. But what happens if should you continue even longer? And this actually comes from the data comes from the Karishma trial, where overall Karishma, which was aspirin versus aspirin plus clopidogrel, was negative. But in the MI patient, the patient with MI, prior MI, as you see, there is a significant reduction in the primary outcome from 8.3 to 6.6, particularly with the dual antiplatelet therapy patients. Without MI, there was no difference. So, taken that concept in a large number of patients, hypothesis of the Pegasus trial was that addition of ticagrelor to standard therapy of low dose aspirin would reduce the incidence of major adverse cardiovascular event during long term follow up with patient with acute MI. And these were the 3 arms: 90 milligram twice a day of ticagrelor standard dose, or the low dose ticagrelor 60 milligram twice a day, or placebo. All patients received small low dose aspirin from 75 to 150 milligram, and of course the primary endpoint outcome was 1 year follow up, and so basically what did it show? That as you can see, the placebo had a 9% event rate, with the ticagrelor both groups had 7.8% primary endpoint. So clearly favored both low dose as well as the standard dose. Now as you see here, these are the individual endpoints, and basically the difference comes out down to, in these particular patients, there was a decrease in the coronary death, and of course the death and MI as shown here. Now what about the bleeding? Now if you see here, you compare with the placebo, that clearly that bleeding was higher with both the agents, low and standard dose, but with the middle dose, which are low dose 60 milligram, tend to have a slightly lower bleeding rate compared to the high dose. So then you can make it a point in this chronic patient that you could use a 60 milligram twice a day rather than 90 milligram, and of course there was a lot of dyspnea and so on and so forth. So clearly these two studies will change our practice, and we are going to see over that how they will will be generalized after this meeting. With that note, Anu is ready. She has engaged the guide catheter, and we are ready with the large angle.
Yeah, so we are going to use the Supercross 120, and also I'm just going to show you the type of curve that we have made. I think in the handbook I did mention about the various type of curves, the C curve, the L curve. I would say this is what is called a exaggerated C curve. If you can see, not just the C, the tip is actually facing, it is more of a acute curve here. Despite going to the, 120, we will need this curve to get into that PDA.
Okay. So now do you want to just try without putting the 120 case, or we should? Yeah, let's get a 120 ready. Show this 120. So we are going to show the use of this angulated device today.
Now the only thing would be getting this in the, flush it with the.
So, I mean, as you proceed with the case, as you have correctly mentioned, there are numerous practice changes following these two trials, which we'll talk about.
Yes. I mean, I can tell you with the depth, and now coming back with the Pegasus, I mean, there is a lot of enthusiasm, or you want to say that data accumulating, that particularly in the post-MI patients, that it makes sense prolonged antiplatelet therapy rather than just limiting it to our small whatever used to be 1 year and so.
Clearly, the question is going to be that do these newer agents, in particularly ticagrelor, do they have secondary prevention abilities post-MI?
Absolutely. And the other point, basically, I would say that I wish they would have made a one arm that particularly with the, even with the high dose, that skip the aspirin, because that is will be the part of the new upcoming trial, which is a Twilight, where Roxana Mehran is the PI, that basically that after 3 months you skip the aspirin, because some of the benefit or bleeding of the ticagrelor probably are mediated with aspirin, and you probably don't need that.
You want to go to that view?
Yeah, okay.
So now I'm going to go all the way to the AV continuation.
So tracks very nicely in this tortuous vessel. This is the 120 you had mentioned, Anu?
Yeah. Some dye.
Yeah. So now the wire has been distal. Yep. So you have brought the device distally, pull back the wire into the device. Just when device is nearby the lesion.
Some dye.
See more.
Rotating it a little bit. One negative part about this is compared to the venture, not able to, because you still don't know three-dimensionally where is the opening of the PDA.
But as the torquing, you feel 1-to-1?
Yeah.
Okay.
Now went in.
I think you became.
Yeah.
See that?
Right.
Yeah.
So besides these,
No, I had to do some rotation here, so the catheter will. You could see the movement of the tip.
you feel this could even have applications in CTOs?
In
Angulated CTOs, yes.
Yeah. Okay.
I mean, if you have osteal CTO of the osteal LAD and you're trying to do antegrade, and you really need to, leave this at the left main. No, this is over the wire.
Okay. What
That's
wire?
the only thing. I don't know. You want to use a 300, this one? No, not Grand Slam. You have 300 fielder. See, the only thing is this is over the wire, and since it is a fixed curve, that curve is going to stay like that. Compared to venture, you can undo your curve as soon as you gone into the side branch, then it becomes like any tracking catheter and advance it. So this could have potential problem in the sense you really have an angulated circ, or you have you have the circ where you have OM is okay, then you are trying to get into the distal circ with an angle. There could be you have to negotiate from left main to circ, then from the circ to the distal circ, in that kind of two angle situation, that this may not track compared to the venture, where you can undo your tip, make it like a straight catheter, and then track it over the wire.
Yeah, we have the balloon. What we are using?
2.5? Yeah.
Yeah, 2.5 is good.
2.5 is good.
Yeah, now the question also comes that now you need to open this branch, and your atherotomy, flextome or the angiosculpt, or now actually we are using chocolate balloon in some cases
And
that may not make that turn. So that you want to.
And now when your wire is coming out, you just have to be careful that you are not in any plaque. Yeah, good. Okay.
Now let's take it out first. Not be able to see anything.
Okay,
Yeah.
good.
So any special precaution you need to take when you are withdrawing this catheter?
Yeah, that's what.
No, but now on the wire is no
Yeah.
problem.
Right.
But if you have no wire, then it's of course that it is going to scrape it. So therefore, once you go distally, you have to pull back on the wire till you think at the near the ostium. 1 second, let's advance a little bit. It's coming back.
Yeah.
Advance. Okay, good.
Okay, it's out.
Okay.
Now let's cut the wire.
Yeah.
Now what you can do is, we have the 300 fielder, we can cut the wire.
Or you can stabilize. You know, other thing also you can always do is that stabilize the wire. But anyway, we are ready now. Good.
So just going with pre-dilatation, or you're
Yes.
using
Yeah, we're
some.
just going to do a pre-dilation now.
Okay. Samin, this may be the right time to follow up on some of the two trials you mentioned. A very large trial matrix, numerous centers, far bigger
What's
number
the
of
stent you want?
patients.
Stent?
Yes.
You think it has eliminated the issues which came out
3O?
regarding bivalirudin and heat PCI?
3016 you want?
Well, I mean, again, the only problem is the whole thing portrayed as a negative, that the bivalirudin did not meet its primary endpoint, and the primary endpoint basically was significantly reduction in MACE.
But what
Although
do you,
there was lower mortality.
right, that is
Yeah, I know. You want to put a wire into the side branch or no?
No,
Okay. Ready?
go, yeah. So you want to put a 3O?
Yeah.
what size
So you have
balloon is
a
this?
distal RCA is 3.5, PDA probably just about 2.5 to 2.7. So I think what we can do.
275, yeah. In proximal, we can dilate with a bigger one, but 275.
No, then the question you want to put a 3.5, no. Put a 3.0, 3.016, and then we can post dilate the proximal distal RCA to 3.5. 16 is good.
Yep. Take a picture.
16 is good. 20 will be too long, right?
No, actually, there is a mild disease now, or maybe because the wire, you had 20? I would, yeah, 3 or 20 will be better.
That is a typical look of the side branch. If you see the AV continuation, it could be by the wire, and also our pre-dilation that has done that. Do not change the plan.
And after you
Not
put
to
the
wire
stent,
the side branch.
On the basis of matrix, more transradial cases for STEMI?
well, I mean, I would say that although we are not the radial fanatic, but I can tell you I had to make a statement, and that is in one of my take-home message, that after radial intervention now with the number of these cases and supported by the MI of the rival and the rifle stacks trial, which have looked into this aspect of what happens in STEMI radial versus femoral, I think there will be maybe a class 1 indication of the upcoming the focused review update of the PCI, that the radial PCI should be preferred as a class 1 in acute MI patients. I think there is enough, this will give you enough background and enough support to those statements, because this is now the multi-center randomized trial to answer that question, and there is associated lower mortality. So this may go with long way to making that claim that in acute MI setting, the radial intervention is associated with a lower mortality and therefore should be a class 1. And we know, just like the freedom has been incorporated in the stable angina guidelines, the 3-vessel disease or 2-vessel where LED could be stented, take a picture, that those are part of the new guidelines now, so it may follow the same routine.
This 3.0,
Yep.
it's not 2.7, so
Right.
don't go high pressure.
Okay,
Go
we are
on.
going up now. 12 atmosphere.
Down.
So absolutely based on
Yeah.
your illustrations during the presentation, there was no need here to wire the.
Yeah, because there was no disease here, and the angle, particularly because angle is almost 90 degrees, that the chances of clearly will be less of the side branch. But
plaque
some
migration.
people will routinely just do the wire and not necessarily dilate, and
Go
that is
here.
the key.
Go up here. Dilate.
Now this is the proximal lesion which gave the trouble, so we are dilating that because you are going to stent that area later on.
Okay, down.
And the same stent will.
3538 approximately.
Yeah, or 4 even. That's a big vessel.
No.
Okay, 3.538. But both lesions of the proximal and mid will be covered. Take a
So
picture
you
now.
abandoned plans to demonstrate OCT?
No,
No, we will after the
After the-
stenting. We
okay.
said
Yeah.
plan was after the stenting because we you have
So
multiple tight lesions.
Some plaque shifting there?
Yes.
Yeah, that's what we are going to show. What OCT will it looks like. This is what you normally see.
So the interesting part would be I am going to have you make a call that by angiography would you leave it alone, and then we'll see how much OCT changes that.
Yeah. Well, I mean, we get a little more verapamil because some of the, what are the reasons for the side branch occlusion? One, that you have created a dissection, but more common is either spasm or snowplow. The part of the plaque has gone to the side branch. So that basically by giving vasodilator, you will reduce the spasm with the nitroglycerin as well as by the verapamil, which we have. And then of course, with good antiplatelet therapy, if you have less suboptimal antiplatelet therapy, that will more chances of thrombus of the side branch. And of course, once you have really the plaque there and it compromises flow, you have to go back in. But in this particular case, as we talked about, and the data are clearly emerging, that if angiographically looks bad, even if it looks bad, that you should not wire. We need wire more. Yeah, that you should not routinely stent it unless you see it's a TIMI3 less than TIMI3 flow or patient having EKG changes or chest pain.
Not
So far, patient has no EKG changes and definitely no chest pain.
what stent is this one now?
This is a Promus
Not too long?
38. I mean, we are trying to cover two lesions, the proximal and the mid. Some dye there. Did we get in?
Yeah, that will
We
be
are
okay.
okay,
Yeah.
right?
Yep.
A little bit inside. Okay, ready?
Good.
You want to take a picture?
Okay. Your wire need to go further.
That's okay. Leave it. It's a very distal side branch.
Good.
Okay.
Okay. You
Go.
ready?
Go.
Yeah. So I think the 32 would have been a little
Yeah.
smaller, shorter. So I think this is 3.5, 38 at 16 atmosphere. It's a big vessel.
Yeah, we'll cover the distal lesion
Yeah.
very nicely.
Yep.
Are the OCT ready? You want to post the distal RCA? Let's
I know
see
this
the
was the
clear-
6 French system, no?
Yes.
Yep. All 6 French.
Unless you're thinking of a dedicated two stent or rotational atherectomy with more than 1.75 burr. Majority of our cases are 6
That's
French.
good. Okay.
Coming out.
Get OCT ready.
Now you want to take a picture and you have to decide the distal RCA. Do you want to post dilate or we are
But
okay?
we'll take this one out anyway.
Take a picture so we get it. We needed a longer despite we went too much into the PDA.
That's okay. Good.
I think we don't have to post, right? Looks
Yeah.
okay.
Looks good.
OCT.
So Anu, what would you expect on OCT here?
How the side branch would look now.
Yeah. Let's take a good side branch view in AP cranial.
So on the basis of angiography, most people would probably
We
leave this
will
alone,
leave
no?
Yeah.
Okay.
Now in this view, okay,
Yep,
let's go to two views, right? Let's go to LAO view. Looks okay.
LAD we already did LAO.
We did. No,
Yeah.
we do
Go
one
to
more.
scene minus. LAO we already have.
Okay, go here. So if you look at the AV continuation, right?
Yes.
Goes on so-called normal vessel, maybe we would say now there is a 30% at the after we stented. Now let's go to another view.
And particularly where you see the ostium. Now just one second, little off. Flora. 1, 2, 3, yeah, that's good. That's better.
Now if you see here, you see the haze that we normally would see in any side branch. It's a big vessel, and that's what I demonstrated in the diagonal. Usually you always see it. If they don't have chest pain, EKG changes, we know we are not going to do anything. But if the patient does have some minimal chest pain, interventionalist always will be in two minds. Should we do something to the side branch, or do we just leave it alone? Huh?
He has some chest pain.
Oh, he's having chest pain.
Okay.
This one.
Okay.
It's also very large branch.
Yeah. Now, while OCT is very good in terms of delineating the mechanism of these kind of disease process, the one of the big issue remain that you need to give a large amount of contrast. So have to be careful.
Large amount of contrast, and this is the distal. We are going all the way down.
Yeah.
We'll see with 12. If not, then we go to 14. Should be okay. Yeah, where are they? 74? What do you want, 74? Come closer. Do you connect it? Actually, in this room, we have a co-registration. What co-registration is, you will see, you can see it, right? We'll do a cine.
And that the 3D angiography which showed was the product of post processing.
3D angio is totally different. That's post processing.
Yeah, post processing.
But this is co-registration with the angio when you see it. We see it good, right?
Yes.
Yeah, so we have 3 cc, 12 and 0 rise.
Why are they not showing the angiogram also in this? They will show it later?
No, later okay. It comes, not now.
Yeah.
What magnificent pictures.
No.
Take the wire out, okay?
Yep.
Don't need to see anything. So when I meant co-registration, see now, you can you have to do the cine angio at the same time, and they're just going to put the dot and connect everything. Are you showing it?
Yes.
Good.
Co-registration failed.
No, you put too many dots. I think when there's an angle, it can fail. 1, don't put too many. Yeah, that's enough.
Good.
Don't put too many.
Good.
Okay, good. Now you will see the OCT. So very important there. Now when you see that, right there at the side branch. Okay. This is what we were talking about. What I am telling you is the plaque migration. We are not going to, this is a new term that we have been using, that it's not snow plow. It's not that the plaque has gone into the side branch. But if you go back to show where that side branch is coming up, yeah. You start seeing it covering the stent. But the true side branch is okay. Go back there, go back, exactly where the side branch is coming back. Back. Yeah. That's the PDA, right here. It's starting side branch, and there's a little bit of migration of the plaque into maybe one quadrant. Yeah, that's the side branch ostium. Yeah. This is the plaque migration. That's why you see that hazy look of the AV continuation. Come back, going forward. Side branch is right there.
Now,
Okay. Yeah.
That's fine. Done.
Got it, right?
Yeah.
So clearly based on this you are going to leave things alone.
Yes.
Would that have been the same decision if this was a BVS?
Yeah, I would say
Okay.
the same.
Same
All
decision.
except that BVS struts
We
are
don't
bigger,
know.
I mean thicker, and they may obstruct the flow
More.
just angiographically more, and that is what some data have shown. But clearly that is the first generation BVS or second generation actually now. But the newer generation I'm sure will translate into a lower or thinner stent struts, and will continue to do a good job even covering the side branches,
Can you
because
show
that is
the
what we
3D?
don't worry about now. We don't worry about the side branches now with the newer generation
Yeah,
stents.
this
in
is the
majority of
second
the time.
generation stent. I think we do not worry about the side branch, but I think in the situation, how is it? Still having pain? Better?
Gone.
Huh? Better? We give
Pain gone.
more.
Yeah.
Yeah, but we give some medicine also. In this kind of a situation where we know it's a large side branch, confidently we have stented across, there is some haziness, some amount of chest pain is there, that are we confidently coming out of this case not to do anything for the side branch other than giving the usual, what we tell is give psychotherapy to the side branch. Vasodilators.
Samin, a couple of key questions have come in. The first one is coming from Dr. Nick Cruz from the Philippines. He does communicate with us often. Why not use OCT to help in stent length and diameter selection prior to deployment?
Well, I mean that is the good point, but basically that you can do by OCT, but then you have to repeat again. I think it will be a little more expensive way to check the lesion length. Now,
Yeah.
reason is that once there is some
So the
issue,
proximal edge.
some issue in terms of the whether you'll cover completely and it is going to change your stent length which you have not, that maybe need to be that precise. I say that we pay too much
Okay,
attention,
go back there.
or we have
Yeah,
paid
yeah.
too much attention to
Stay
the
the
lesion length
proximal
and the stent coverage with the other stents, but with the current DES, you have a 3-4 millimeter. It's probably better to err on the longer lesion stent length than the lesion length. So clearly that you want to cover more beyond your lesion and you don't pay the penalty.
And other thing also, in this particular case, you had a 80-90% proximal RCA lesion, distal with that kind of an angle, it's not safe to do OCT and should not be done. We may not even get a picture. When you have that kind of tight lesion, there is no dye clearance. That will be putting the patient into risk of going into VFib when we completely give the dye. But there is another way of doing OCT by giving a dextran, which we want to start doing it here. Because stay there, proximal edge. Yeah. So this is what, remember we saw in the angiogram, the little hazy look at the proximal edge. This is a little bit of, if you see at 12 o'clock position, dissection of the proximal edge. But this is angiographically as well as by the OCT, we are going to leave this alone. You don't go behind this.
So, Samin, there is
another question.
Yeah, there is. I do not know where this the question is coming from, but they were concerned and they suggested that they may have done a wire protection here.
Yeah. Well, I would say leaving the wire in the side branch is nothing wrong in that. To me, it actually favors your side branch protection, so that just by having a wire branch, I personally will do. Majority of our cases, I leave the wire, won't dilate, but leave the wire. Just presence of wire, in my opinion, should be it does prevent side branch occlusion for various mechanisms which are ill-defined. One could be simply there is a foreign body in the side branch, so all the snowplow effect not occluding it completely. Secondly, making lesion a little more favorable. So now putting the wire into the side branch, making it less angle, so it preventing it the occlusion of the side branch.
I think despite doing the OCT and demonstration, I have failed to convince a lot of people that you don't need to leave a wire in the side branch. I think the room 3, which is Dr. Sharma's room, always gets the side branch wire. Room 2, which is my room, fellows know there is no side branch wire, and the outcome are the same in all these patients. So, but a lot more to go. I think one day we will probably say that in the patients without any side branch disease or disease less than 30%, you do not have to leave side branch wire, stent across and be happy.
All
Well,
right,
it's
let's finish. Yeah, sorry.
certainly the easier of the two approaches,
Yep.
but good to have a little different opinion in this matter. And
That's the way
hopefully-
you push the science. There is
Right.
of course. Now we can just quickly finish it. We are reaching our time. So two important messages. That important emerging technical aspects of bifurcation PCI are: avoid treating side branch before stenting, jail the side branch wire, we just talked about, perform side branch PCI only if compromised flow, importance of side branch angle, how it will predict the occlusion we still need to see, avoid routine final kissing balloon inflation unless two stents are used, and select plan two stent strategy in appropriate cases. Where you think you are going to need two stent, plan with the two stent, don't use as a bailout two stent because that's where you have more complication. Second, the matrix trial further confirms the notion that transradial approach should now become the ACC class 1 indication for intervention in MI patients. Prolonged DAPT using low dose ticagrelor in post MI patients should be routine, especially in patients with low bleeding risk. Now we go to 3 questions. In the bifurcation lesion PCI, following are the appropriate statement except: jail the wire in the side branch, stent the main vessel, dilate the side branch if less than TIMI3 flow, perform final kissing balloon inflation routinely, and lastly the side branch PCI decision should be made by FFR, the side branch. Second question, matrix trial comparing transradial approach to transfemoral approach in ACS showed the following: except TR is associated with the lower MACE, TR is associated with the lower NACE, TR is associated with lower CVA, TR is associated with the lower death, and the TR is associated with lower bleeding. The third question, following is the true statement from the Pegasus trial: the lower MACE with the only low dose ticagrelor or only with standard dose ticagrelor, or lower MACE with both low and standard dose ticagrelor, and higher bleeding rate with only standard dose ticagrelor, or higher bleeding rates with only low dose ticagrelor. So these straightforward questions, and clearly we encourage everyone to go back and to the archive questions with their answers of this one as well as the previous one, and thank all our audience to be
Samin,
watching
before you go off the tape, I was going to remind people about your upcoming course. How is that coming along?
we just the brochures have been
June
finalized.
17 to 19,
Yep,
I did
and
see a lot of brochures at the ACC.
Exactly. So we just brochures were introduced and they are being mailed. So we want clearly it's a one day is endovascular and 1 day is both structural and coronary. We decrease from 2 days to 1 day because we have this monthly teaching for both coronaries as well as for structural heart, so that we said, well, let's concise and just talk about the latest data in this field and do the selected complex cases, particularly the bifurcation, calcific and CTOs, and few tower cases.
What about the fellows interventional?
And interventional board review remains the
1 day before.
One day before.
Okay.
Yep. Yeah, Anu, you want to show and complete?
Yeah, just to tell you about, maybe the teaching point in this entire case is the angulated bifurcation lesion. How do we get into this PDA? That, the first question always we raised was, could you have done it without a supercross? Nothing wrong. You can always try with your specialty wire. Do not try this with your workhorse wire. Always go with your specialty wire, maybe Fielder Whisper, whatever you have. Try to see if you can do a cross without a few means give it a little time. If it does not, open one of these catheters out, whether it is venture or supercross. I just want to show you that in venture we know distally, you'll be rotating it to make the angle, but here this particular tip is already comes with a curve which is fixed, which you don't have to worry about. Like I showed you, you go distally, and as you're coming back to how to get into the side branch, since it is 3-dimensional, you may not be able to see it, but what you can do is just rotate here with your right hand, so that then the tip of the catheter also rotates and get into the side branch, and then just advance your wire as we had shown in this case, and then advance the this catheter and exchange into a 300 wire.
Okay, all right.
Samin and Anu, thank you. Excellent teaching points, and hopefully they will help you in advancing your techniques for angulated and bifurcating lesions. Please join us for session number 70, which will be on April the 21st.